All right, great. Um, if people are interested, there is more information about diagnostic stewardship out there. I'd recommend two big resources. One is there's a course, it's a half-day course before ID week for people who go to the infectious disease meeting. And there's also SHEA task force papers. The Society for Healthcare Epidemiology of America has a task force that I co-lead. And we have four papers that are free online for people who are interested. And I'll mention those again. So, in talking about diagnostic stewardship, I mean, I know there's people from a range of different backgrounds here and a lot of people in nursing homes. I'll try to have a bit of something for everyone, but it's really about how we can test better to try to have better patient outcomes. Some of this is certainly driven by metrics, and that gives us a lot more leverage to make changes or to get people's attention in the labs. But the ultimate goal of all of this is how can we better take care of patients? And I think that as we get more and more tests, it's easy to realize that they aren't always good, that they can be helpful when used in the right way, but they can be unhelpful if used them without thinking. Some overarching threads that I'll hit on again as we go through this, but there's a conceptual model for diagnostic stewardship. It's a pretty straightforward one. This is really about how we implement tests. So it's not just how doctors choose to test or not, but it's how they are in the system and how you can make them be used more effectively by putting time into how they appear in the electronic health record, or whatever system you use to order tests. And I'd like to emphasize this isn't about oversimplifying diagnosis. I think there's a lot of testing that's not done ideally because we don't think about it too much, really. But there's a lot of nuance to diagnosis and testing too. So it's not like we want to get rid of the nuance or have people not think about that. But I think just to try to lessen the poor use of test. And then there's some terminology that I find a little bit confusing in this. The microbiologists have been talking about diagnostic stewardship under different names for a long time, and they call things pre-analytic, post-analytic, and analytic, which I like the idea of calling them ordering and lab processing and reporting better because I know what those are always. But you will hear these terms if you are around microbiologists much. Okay, so just this is just to emphasize the objectives of diagnostic stewardship, and the top one really being improving patient care. And the reason that I want to emphasize this is that I do think we often will do this because it improves costs and metrics. Like you can reduce costs in tests, you can make your HAI rates better, and that's all good. I think we should also try to make those numbers better, but really keeping the patient care is the primary outcome. So there's been a lot of publications in this. It's definitely a growing area. The term has been used more, um, and it really is kind of a new field. So it really started around 2017 or so. At least like the term started to grow, and I think part of that's because testing is a relatively new phenomenon. And if we think 50 years ago, there just weren't that many tests that were available and could be used rapidly. And a lot of those were done by doctors themselves, like in a lab. And so people understood what they were doing better than now we send off samples and we get results back. And it's a lot harder when you're distant from it to say, hey, that's an abnormal result. But yeah, I know what it means. I ran that. Sometimes they're wrong, or sometimes we shouldn't pay attention to them. Um, there's different movements in medicine to focus on diagnosis, and I'm going to try to push those together some. And that really comes together in a CDC document that came out last fall called the Core Elements for Diagnostic Excellence. So similar to what most of you are familiar with antimicrobial stewardship that had a core elements that really pushed the field forward, there's a new one for diagnostic excellence. But in 2015, the National Academy of Medicine came out with a report on improving diagnosis that talked about diagnostic error and diagnostic excellence, and that got a lot of people thinking about diagnosis. Around 2017 is when diagnostic stewardship came out as a term. And then the SHEA task force was active more recently and had these four documents in 2023 and 2024. And then in 2024, the CDC came out with core elements of diagnostic excellence, which I think is a great document. I spent a lot of time working with people at the CDC on this, and it came out fortunately before the CDC went dark, but they are interested in promoting it, and it's potentially a tool that can help people get more support from their leadership. Similar to the core elements of antimicrobial stewardship, where one of the big parts of that being successful is that it tells leaders you need to pay money to have a program. And that really is, I mean, a lot of the document, you read it and you're like, oh, those are all simple, straightforward things. But like having leadership be committed to supporting, obviously does a lot to make it more effective. And this bar at the bottom is just the number of publications that mention diagnostic stewardship. So you can see it's been increasing from like basically being non-existent to about 150 publications last year. So it is catching on. So I mentioned we do a lot of tests. This is data from about 6 years ago from the CDC, but we do about 14 billion tests per year then. And that would be 42 tests per year for every person living in the United States. So we are heavily tested. And of course, we know this is some people, are tested like 1,000 times, and others of us aren't tested at all. But there's just a lot of testing happening. And, it's no surprise we have companies like Theranos popping up saying, like, we should just do more testing and it would be better. And thankfully, they were fraudulent. But because if their idea works, then we'd have to deal with all of those test results. Okay, so the conceptual model, I often don't like conceptual models. In the research world, you have to include them in grants and other things to kind of justify the thinking. But to me, this is a relatively simple conceptual model. And it's the idea that testing is more complicated than just like a clinician and a patient being together and then ordering tests and results coming back. That there's what I think of as kind of like the area under like an iceberg, but the underwater part. There's all these things that happen when you order a test and the test is collected and then it's taken to the lab and then it's processed and they do different things and then the results come back. And each of those steps can be modified to probably improve the way that we order tests, but the way that the lab runs them and then the way that we interpret them. And there's details in this that people are welcome to look back on, but I'll cover these some in examples. So these are the SHEA task force papers I mentioned. They are in infection control and hospital epidemiology, but they are open access on the SHEA website. And so the first one I think is the most general, is Principles of Diagnostic Stewardship, a Practical Guide, written by Valeria Fabre is the first author. The next one is talking about the relationship between diagnostic stewardship and antimicrobial stewardship, that often it's the same people doing these, and they have often the same goals, but there's some differences in how they achieve those goals. And then we know that a lot of diagnostic stewardship was spurred by the desire to push down metrics, and things like C. diff metrics or CLABSI metrics are heavily influenced by diagnostic stewardship, because if you don't have a positive test, you don't have a positive metric. And I think that's both good and bad, but it's things that are worth thinking about. And then, of course, during the COVID-19 pandemic, everyone learned about testing, right? It became like a common dinner conversation. And, do you test before you go to work? Do you test before a vacation? All these things that really made testing much more front and center, even if, I think we all still have problems thinking about testing. Okay, so diagnostic stewardship, again, I'm going to repeat myself a few times, but I think that may be helpful for a few takeaway points. One, it's really about implementing testing. So it's about trying to implement somewhere in these steps in the conceptual model. And often it's just one step. So it's not needing to change everything, but just one place. But if you have problems, you can think about the process and how to modify things. And sometimes people say diagnostic stewardship when they're talking about clinicians deciding what to order or to test or not. And that often kind of veers into this area of diagnostic excellence, which I think is a little bit more of kind of a clinical reasoning, medical decision-making type world that I think of as a little bit separate. And I would emphasize that this is about optimizing testing. And so if we think about our goal is to hit the target, we're trying to sort of hit the middle and not do things too infrequently, but not do too much of things. And I think, for infectious disease, and at least a lot of the tests that I deal with, the problem probably is that we have too much testing. We do urine cultures kind of as screening in the emergency room. And so there is too much. And so a lot of it is about decreasing overuse. But I think sometimes it's about assuring a test is used when needed, right? We obviously know that sometimes you can miss things if you don't use a test in the right place. And any of us who've worked in areas where you don't have access to tests feel a lack of like certainty around what you're doing, that you really feel like you're guessing in those areas. And so that can be, we can try to make certain the right tests are done at the right time. Like rapid blood cultures, I find very helpful to do rapid identification off of blood cultures in the hospital, and to really have the information about if it's a resistant bacteria sooner than later. Sometimes it is about using a new or more expensive test, like sometimes a multiplex panel, although it's often not. But I say this all to focus people on the idea that it's about better patient outcomes, and we should be thinking about like what's the sort of the downstream effect on patient care when we're thinking about how to change the way testing is available, and being smarter about that. So I mentioned before, I don't want to oversimplify medicine. That it's easy to talk theoretically, but when you're seeing patients, patients are all different. They're confusing. We're uncertain about things, and I think I myself test sometimes when it's not maybe optimal. But if I think having a reason is thinking about it is the key part. And we really can't define best testing in all situations, that there's lots of different situations out there. But I do think we can improve the wrong practices, like when there's things that happen routinely that aren't really done for a reason, and people may not even feel that strongly about, but it's just like the path of least resistance, or it's what they've done without thinking, or it's part of an order set. We can do things to improve that. A lot of this relies on the ideas that come from behavioral economics, the idea that you can kind of frame results differently, or you can nudge people to do the right thing. And I think that we should always allow variation or request. So we don't want to be too dogmatic about it and force clinicians to not be able to do what they want. And so I talked about behavioral economics, and this is really a reframing of psychology. So psychologists, thought about biases and how we, don't always think rationally. Kahneman and Tversky are the people in the older picture. They seem like kind of fun-loving psychologists back in the '60s. And then the economists took it over. So this is Cass Sunstein, who's like a very serious, economist, and got the Nobel Prize for doing this. But he was famous for calling it paternalistic libertarianism. So you're telling people what to do, but you let them always have the option to do what they want. You just make it a little bit harder. And they used it in the Obama government, that a lot of federal employees wouldn't save for retirement. And if you're a federal employee, you get great retirement benefits, but you had to opt in, so you had to choose to check that box to do savings. And so they did this very simple thing. They just had people, they required them to opt out. So they didn't force anyone to do anything, but like when you start work, like it's pre-checked that like you'll give deductions to your savings account, and that will be matched by the government. And if you don't want it, you can always stop. And they like doubled the rate of people contributing to retirement, because most people don't think about it, and most people don't put that much attention to it. So it's trying to make the right thing happen when people don't, when they aren't thinking, or they're too busy, or they don't know what it's about. All right, so the people who've thought about testing a lot in the hospital too, especially for infectious disease, are clinical microbiologists. And I think there are some differences that are worth being aware of, especially if you're trying to implement something. You're going to want to talk to the clinical microbiologist, or the people in the lab who will be doing things, because there's often rules related to the lab. And you need to have agreement so that you don't confuse the clinicians who are trying to order things. So I think diagnostic stewardship, in being something new, is more clinician oriented, and is really focused on how we do medicine, and how clinicians sort of orient their days and why they do what they do. And that's the real advantage of it. And focusing not just on sort of how well a test works in the lab, like how well it will detect a sample if you put it on two machines, but how well it will detect a disease in a person, which is a much harder task to get to, because sometimes people with a disease don't have a positive test, or they do when they don't have the disease. So there's like much more complexity to it. But I think that complexity is part of diagnostic stewardship. But the lab can really help, because they understand how labs are performed. They know the processes, they know the rules that govern things. And they're the people that are called often. If someone wants to get a test and they can't get it, they'll call the lab. So if the techs or the lab director are on your side, they can really make things work much better. And the same holds true for trying to extend this to like general lab testing and radiology. And I would note this happens probably more in other places where ID doctors are trained as medical microbiologists. So the same people who do ID consults also run the lab. All right, so a little bit more about language. So this is that same conceptual model. And this just to emphasize the microbiology language that people will see if you read this literature, that pre-analytic is anything that happens before the lab. I've always thought this is a little self-centered of the lab people. Analytic is what the lab does. They are the ones who do analysis and are thinking about things. And there's pre and post. There's like before and after them. So these are the words you'll hear though, and it's the same idea as that pre-analytic is about how you order tests and how they get to the lab, and then post-analytic is how you report the results back to people. All right, so some examples. I know a lot of people deal with CODI and with urine cultures, and I think it's one of the kind of low-hanging fruits for diagnostic stewardship. So this is an early article that I'm highlighting because they've is back when I think people were figuring out about how you can change testing and the impact it has. So this was from Cleveland, and they had a multidisciplinary focus to reduce CODI rates. And they did different things, but then they really switched over to focusing just on culturing and trying to reduce culturing. And a big part of that was trying to get them not to culture people with fever. The idea that like you have fever and you should pan culture people is common in the hospital. And so they tried to push people away from that and say only do cultures without symptoms in the setting of kidney transplant or people being neutropenic or some particular higher risk factor. And this is what they found. The blue bars are the number of cultures performed per quarter. And what you can see is the number of cultures performed dramatically decreased. It went from like over 1,800 per quarter down to like 300 or so. So it shows that we're doing a lot of cultures in an ICU that just probably weren't necessary. And I think when you look at practices, often you realize that nobody cares. It's not that someone wanted to do more cultures; it's just that that's what they did, or that's what would happen automatically. When there was, the resident who would get a call would say, like, the nurse already collected the specimen, and say, sure, I'll put it in the computer. And so you'll see just a lot of stuff that happens. But when they intentionally tried to get people to change practice, they really reduced the rate of culturing, and that reduced the rate of CODI. And so that's I think the benefit, just like antibiotic stewardship can show that you save money by reducing the use of expensive antibiotics. Diagnostic stewardship can show that you improve the metrics, and that's what the C-suite cares about, but you're also improving patient care. So this is another paper that I think a lot of people have seen. This is from Valerie Vaughn led this when she was at Michigan, and they had a 46 hospital collaborative where they do patient safety initiatives. And so their goal was to reduce the number, how many patients were treated for asymptomatic bacteriuria. So people who were presumed to have UTI but didn't have any symptoms. And the way they did this is they had benchmarking of performance and sharing best practices and pay for performance. So there were a lot of these kind of administrative prods to get hospitals to change practice. And so this is their main finding, that they over time, from the beginning of this initiative to the end, they were able to reduce the number of patients who were treated for UTI who actually had ASB. And so this went from about 30% down to 17%. And they noticed that of those people who didn't have any symptoms, so they had chart review of these cases. So the patients who had a positive urine culture without symptoms, they still got antibiotics. So the real change was that people didn't get cultured as often. And Valerie is fond of saying that, like, diagnostic stewardship, eats antimicrobial stewardship for breakfast when it comes to, urinary tract infections. Like, people have a hard time not treating a positive test. But if you don't have a positive test, it's a lot easier to not treat. And I think in nursing homes, this is, an especially important issue. And it's tricky, of course, because like often you don't have a lab on site. The results come back later, but you want to really think about ordering tests and how that will change management. And it's not that you shouldn't order tests, but you shouldn't do it kind of in a reflex type manner. Okay, and so what can you do to improve urine culture diagnostic stewardship? Well, I think there's three main things. One is to improve ordering. This is a little bit more complicated because this is often like building something into the electronic health record that when you try to order a urine culture, you need to give the indications and basically show that somebody has symptoms that would drive this, because you want to treat people with symptoms and not treat people who have asymptomatic bacteriuria. The probably the simplest thing that can be done, and what we've done at my hospital in different ways, is only culture the urine if there's pyuria. So there's different names for this, and the reason I say only do it with pyuria is because it's a little bit confusing, but like this is called reflex culturing or conditional culturing. But the idea is that people who don't have white blood cells in their urine don't have an infection. And so if you can create a pathway where anyone who has a urine culture ordered will have a urinalysis done, and if there's no white blood cells there, then they won't have the urine culture performed. You can stop a lot of unnecessary urine cultures. And so there's sometimes some argument about what's the best cutoff. Is it like greater than 10 or greater than 25 white blood cells? And I think there's issues around what you could name it. Like in our hospital, it was called urine culture, and people just ordered urine cultures normally. We switched it to urine culture with, we called it urinalysis with reflex to culture, which seemed okay. But then we started to find that a lot of people were ordering it when they wanted a urinalysis, or they'd be like, well, just get a urinalysis and it'll do a culture if you need one, with the idea being that like the lab knows better than the clinicians. And so we changed that, and we eventually just went back to urine culture. And now it's urine culture, and in the report, if it didn't do the urine culture, it'll say did not perform because patient didn't have pyuria. And we thought that would be a big deal. We tried to educate clinicians, and clinicians were like, huh? Well, it sounds fine. So a lot of these times you think it will be a big change. And especially if you try to talk to people more than needed, they tend to say like, yeah, why are you bothering me with this? It's fine. I want to order a urine culture and the lab will do it the right way. So simplicity ended up being best for us on that. The other thing you can do is change the way you report urine cultures. The most dramatic example is at University of Toronto. They knew they had a problem, and so they actually changed it to where the lab report would say urine culture has been completed. If you want the results, call the lab. And their rates of CODI dropped down dramatically. Their rates of treating people for asymptomatic bacteriuria dropped, and they didn't actually have any problems with people not getting treated who needed it. And a lot of that's because we treat people because they're sick. With antibiotics, not just to test alone. But they stopped doing that, and we can't do that in America. It goes against like reporting structures and stuff. So it's a great example of like the most extreme end. And other things we do often have less effect because there's a lot about thinking about what clinicians do when they read a test result. And they're often not going to look for the comments, and they're not going to look for the details. So it's about how can you make it and build into their workflow. And one way, a good way though, is like cascading antibiotic susceptibilities. Just give them the antibiotics that are first line. Like don't tell them the antibiotics they shouldn't use. And if they don't see it's susceptible, then they won't order something. Like, if it's susceptible to 4 antibiotics that are first line for guidelines, don't tell them about the fluoroquinolone, and they won't give the fluoroquinolone. Even though it's susceptible, and anyone who thought about it would know it's probably susceptible, people won't order it if it's not on the list. All right, so moving on to C. diff, this is the other, I think, most common kind of low-hanging fruit. And a lot of places have already done this, and it's a very laboratory-based approach. But it's the idea that C. diff is often colonized as people. And so there's a lot of people who have a positive test without disease. And there's like a lot of this same problem with urine, right? That a lot of people are colonized who don't have a disease. And so this was an intervention that was led by the group at Hopkins, but it was to study clinical decision support to improve C. diff testing, and really focusing on not having duplicative testing or testing people who are on laxatives, with the idea being that if you have a good reason for having diarrhea, you shouldn't test for C. diff in that patient, because you're just kind of screening people for C. diff. And so this was built into the electronic health record. And they tried to look at outcomes of the C. diff rate as far as hospital onset CDI rates that are reported to the CDC, and oral vancomycin or fidaxomicin use. And those, to me, the antibiotics are the most important patient outcome, because that's really showing that we change the way we care for people. And what they found is that there's a 25% reduction in C. diff testing. There was a similar reduction in use of antibiotics, and actually a bigger reduction in the hospital onset metric for C. diff, which will, make your leadership happy with you. And that hard stops. So the idea that like when you try to order a C. diff test, if you're on a laxative, the computer says, no, you can't order that because they're on a laxative. Call the lab if you want to get the test still. That works better than having a soft stop or like kind of guidance to say, are you sure you really want this test? They're on a laxative, because doctors often will just kind of click through it and say, yeah, I want it. So hard stops were effective in improving this. And this is kind of great because it was done centrally in the electronic health record, but then it affected all the people who order tests in that system. So unlike changing education, where you need to train each clinician and new people come in, you have to train them and you have to keep updating training, you could change one thing in the electronic health record and change the way that testing is done across the system. Similar things have been done with blood cultures. A lot of people are more aware of this because of the shortage of culture bottles that happened last year. But this is the sort of some of the studies that defined how we could better use blood cultures. And this is in the PICU. So it's a pediatric example, but there are adult examples that are similar. So they trained people to optimize blood culture use. And then they looked at the outcomes. And so this is a complicated table, but the summary really is that with trying to improve the practice of when to order blood cultures, they decreased the frequency that cultures were ordered by about a third. They decreased their CLABSI rate by about a third. And they also decreased the use of antibiotics with no harm seen in pretty extensive balancing measures they looked at. So in summary, for these three most common tests, which I think are, really the place where to put a lot of effort, that you can see that there's a decrease in the rates of healthcare associated infections, the things we report, the things that your hospital will be judged on, and maybe even reimbursement will be adjusted by, can be reduced by about a third to a half. And then the patient care is better, that antibiotic use can be reduced from, probably about 10% up to, to 50% or so. So I think that there are real benefits, both to what we report, but the patient care that is delivered. I'll say a little bit about molecular tests, just because I feel like those are increasing, and they're somewhat different from these more common tests that we look at. And by this I mean multiplex panels like the respiratory viral panel or a GI panel, or these more complex tests like Carius, which is metagenomic sequencing, or things that have been called like agnostic testing. So the idea that you don't need to look for something, you just order it and it will tell you everything you know, everything that you need to know. And these have really been affected by cost, which I think is a good leverage point for trying to improve how they're used. And I think that the reality is that many of the results you get from them are uncertain. Like, what does it really mean to get an organism you've never heard of, and to tell that to clinicians, and how does that improve care or not? And so I think that the patient outcome again is the one I care the most about. So I'll talk a little bit about just a few examples. GI multiplex panels are a good one. They greatly improve access to testing. I couldn't test for norovirus really in my hospital without sending it to the state. And so, we'd always assume this is a viral GI illness, but it's nice to be able to get that result back quickly, as well as to look for other things. It has great analytic accuracy. So like when you compare samples in the lab to it, like it's very accurate that way. But the clinical impact is often less clear. And that's because, again, people are often colonized with things, and we don't know exactly like how much of something you need to cause disease. We know that it's often used inappropriately. That when you sort of release tests in the wild, some doctors love them and order them all the time. Others don't order them when they should. And, often there needs to be better guidance in sort of stewarding people in the right direction. So some people have created tools to try to use this better, like ordering, electronic ordering changes, such as in our hospital, we implemented one where you're not allowed to order it if people are on laxatives. You need to document they have true diarrhea, and you can't get it on people who've been in the hospital more than 3 days. And that's because like most of what you pick up outside of C. diff is not relevant and wouldn't be acquired in the hospital. And and then the C. diff can be an issue because sometimes you're not wanting to order a C. diff test, but it's on the panel, so you get it regardless. So some places have actually blacked out the C. diff result and don't give that back, which I think there's a lot of good reasons for that. But it's tricky, of course, also because anytime you have a result that's not given to clinicians, people can second guess what happens, like Monday morning quarterbacking. Okay, a little bit more about the CSF panel. This is a great example from Colorado. This is from Kevin Messakar. And this is essentially that like there's this, CSF multiplex testing that picks up a lot of viruses, bacteria, et cetera. But it also like is positive sometimes for of unclear significance, especially in kids with some of the viruses that will pop up and it's unclear if it matters, but then you have a test result and it often changes care. So they realized just like urine, if you don't have white blood cells in the CSF, you don't have meningitis and you probably shouldn't be tested for viruses or bacteria that could cause it. And so they went the extra mile and they talked to clinicians, especially in the ER where this is ordered a lot. And they said, why do you ordering this test in all these people who don't have any white blood cells in their CSF? And they said, well, we order it all at once. Like we poke the patient, we get the sample, and then we put the test in the computer. So they said, if you can cancel the test, if there's no white blood cells, like we'd love it. That would make our job easier, but we're not going to go back and change the order. And so they automatically did a reflex testing with the sample. So you can see in the corner here, where in this gray box where it says meningitis, it will only be run if there's 5 white blood cells or more in the CSF. And so that was the way they reduced testing, they improved antibiotic use, and clinicians were happier. Like it did the work that clinicians would have to do. So I think really when you're thinking about workflows, this is a great example of how to make it better for clinicians, how to make clinicians like what you're doing and not make them feel like you're restricting a test that they would like to have. Metagenomic sequencing, I'll just mention that it's because it's so expensive and of unclear benefit in many situations, it's really been handled in a very expert way that like either having like a tumor board of experts to review and interpret or having restrictions, like you have to call an ID doctor or a clinical microbiologist to get approval to send this out. And I think that this may not be the perfect way to do it, but it's kind of the common approach right now to limit the cost of this being sent out when it often won't change management. Okay, so a little bit about diagnostic versus antimicrobial stewardship. I mentioned before, it's often the same people, the same goals. But I think that the interesting part is if you don't have a diagnosis, often people won't do treatment, right? So if you don't have a positive test, you won't treat. So it's upstream really. And that's what they're trying to represent in this picture that's from one of the Shea Task Force guides that this is sort of changing the diagnosis before you get to the point of ordering and then needing to try to limit or target the antibiotic use in those patients who are suspected or confirmed to have an infection. Diagnostic stewardship can be used broadly, and it has. The same ideas have been used without this naming of it. So, some examples are daily laboratory testing. And, back when I was training, we would just do like all the tests on people every morning, and just sort of set it to repeat until they left the hospital. And, we realized essentially we were like bleeding patients. I mean, I think it's the same amount of bloodletting as like what happened in like 1900, like the daily morning lab draw. And which they thought helped with pneumonia or something. But we're doing the same thing to people, and often to a level that people develop anemia in the hospital sometimes from the number of blood tests, which seems crazy. Like I don't like having my blood checked, and getting poked. And some of these people are getting poked often enough that their actual hemoglobin levels are decreasing. So people used similar approaches to decrease this. And then pulmonary embolism testing is an interesting example because people have thought through this process a lot. And it's the idea that it's a scary thing that we want to prevent, but it's hard to identify. And then a new test came out, the CT scan, that keeps getting more and more like high resolution. So you can pick up smaller and smaller things that often probably don't matter. Like some of these subsegmental or very small PEs probably don't have a clinical impact on patient care, but we treat them the same way as we did the massive PEs that we could detect early on. And so people have worked on these rules like to determine people are low risk and then do D-dimer testing and not do a CT scan in some of those people. Stewardship of other tests has been talked about, like radiology. There's a lot of interest in trying to decrease some of the unnecessary testing there. And laboratory testing, and even things like echocardiograms that are often overdone, and these other tests that don't have a clear benefit to patients. Okay, mentioned diagnostic excellence. This is a broader idea that's had a lot of attention, and it's led by groups like CITM. And there's this core element from the CDC that came out last fall. And diagnostic excellence is more of a clinical idea of trying to, I mean, there's a lot of great ideas and a lot of teaching for clinicians on how to do things, but it's not implemented or kind of hardwired in the way of diagnostic stewardship. So the definition, these are from two leaders, Gurpreet Dhaliwal and Hardeep Singh, is making a correct and timely diagnosis using the fewest resources while maximizing patient experience and managing uncertainty, which all sounds great, but of course it's hard to to do that when you're seeing patients. But I think it's worthwhile for people who are trying to think about this process more, because it's kind of like the theory behind it, and clinical reasoning has a lot of thinking out there, which is helpful for clinicians. All right, so I'll mention a few terms that I think are worth knowing about because they relate to diagnostic stewardship and how we do testing. One is diagnostic error. And this is the idea that, I mean, it really started out with delayed testing, like people who eventually were diagnosed with cancer, and it turns out they had a chest x-ray that had something suspicious, and it was kind of missed until they had worse cancer. But so it started with the idea of sort of delayed and misdiagnosis, but also it includes misdiagnosis or wrong diagnosis. And I think that's what we see a lot more of in infectious disease, with like urine cultures being positive when someone doesn't have disease. And it turns out they're overrelated. They're very related in that, like, a lot of people who have, say, like, who are diagnosed eventually with tuberculosis have been treated for pneumonia like 3 times before that. So there's we tend to find a diagnosis and then we stop looking. So there's a problem with misdiagnosing things, and that we don't like look for what the patient really has, and we kind of stop searching. And they have some amazing numbers, which I think are a little bit over the top, but saying things like 1 in 3 malpractice cases are due to diagnostic problems, 12 million Americans a year, and 80,000 deaths in the US. So that may be a good leverage point if you're looking for like support for what we're doing. I'll mention the term overdiagnosis. I was thrilled talking with Alistair that he was familiar with this. And this is an idea that really started with cancer epidemiology. And it's the idea of diagnosis of a disease that will never cause symptoms or problems, which is a hard concept in my mind, because I think that's not a disease, right? If you don't have symptoms or problems from it, like, who cares about it, right? But it's this problem that when you start looking in low-risk people, you find more things that we know don't translate to problems down the road. And this is a problem with like prostate cancer and breast cancer and things where you do screening and the biopsies aren't perfect. You can't identify an individual patients. But it also relates to, like, say, sepsis and infectious disease, where we've seen the rates go up dramatically, even though the rates of all the infections that lead to sepsis are flat or declining. Obviously, this happens in C. difficile when we moved to PCR testing, and then got better when we often did 2-step testing, and UTI, and et cetera. And so how can we improve this? Well, the biggest thing is test less often when the risk is low. So have a higher threshold for testing. Don't test people who are asymptomatic. Don't test people who you don't think have a disease. And probably this is the most important message from all of this, I think, for clinicians at least, or people who are ordering tests. Don't order tests unless you know what you're going to do with the result. Like, often we order a test because we're like, well, this person has a respiratory problem. Let's order a respiratory test. And then we get a result back and we say, I don't know what to do with that. I didn't want to, have that result. So don't order a test unless you know that the result will help you in some way, will help the patient in some way, really. And realize that in ID, we have to deal with colonization. There's a lot of people who have positive tests because bacteria or viruses are there, but not causing disease. And infectious disease is interesting because we just created a new diagnosis. We used to treat too many people who had asymptomatic UTI. So we created a diagnosis of not UTI when they have a positive test, which is asymptomatic bacteriuria. So we can define that. And it's had limited impact maybe in clinicians, but I think it's a great idea of like trying to create a diagnosis that is something you don't treat with antibiotics. In C. difficile, this idea of limiting testing with laxatives or using toxin is the final test. Okay, so I'll just mention the core elements. Antibiotic use, sepsis, and diagnosis all have in common that these are processes that occur across the hospital. They're not a single group, and they have core elements. So this is the core elements of diagnostic excellence that's on the CDC website. It has a lot of the same ideas that are present in the stewardship, antibiotic stewardship core elements, but it also has an increased focus on patient, family, and caregiver engagement. And it's pushing for having programs that often I think would probably be built out of stewardship or infection control, but maybe diagnostic excellence efforts that are already happening also. And probably the biggest point for people who are trying to start a program is that like they advocate for having dedicated time for physician co-lead and a laboratory or radiology expert co-lead. These were supported, these were co-branded with CMS and AHRQ, so it's not just the CDC, it's other agencies. And it really focuses on commitment from hospital leadership. And if you're trying to take on diagnostic stewardship, I mean, I think for people who found this interesting or would like to do something, I would encourage them to do this. And I think it's really about trying to define a clear goal, get the right stakeholders involved, ensure that unit and hospital leadership supports what you're doing. Define a measure, try to figure out like if what you're trying to do is working, and figure out if there's any harms. Like look at truly the impact on hospital care, and then review and refine that intervention over time. All right, so with that, I'll finish up. So just in summary, diagnostic stewardship is mostly about implementing tests better, optimizing testing, not just doing less, not oversimplifying diagnosis, and including clinician and lab perspectives. And it is part of diagnostic excellence, and there is the CDC core elements that I'd refer people to. Thank you very much for your time, and happy to talk to you about this later. Or questions now, if anyone has them, certainly. But I won't get between people in a break, right? Is that
yes,
next?
Yes. It is time for a break. We are going to be splitting the room in half. Long-term care will be on that half of the room, and the general session will remain over here. So when you come back from break, feel free to move around. If you're in the long-term care track and you haven't grabbed a binder yet, make sure to grab a binder from up front because we'll be going through that too.
Yeah. Yeah. Yeah, the hum of the crowd.